Fine. Cool. Let's kick off. So you should be able to see that. Excellent. Good. So what we're going to do is we're going to basically take a deep dive into the AKT feedback report. After every AKT, there will be a feedback report. It's normally released about a week or two after the actual exam results. If you're revising, if you're doing or prepping for your AKT or know someone is, I would strongly recommend that you focus on this and that you at least sort of have a glance of it. You can find them really easily by just typing AKT feedback report. And I would suggest, if you've got time, that you have a look at the last couple. But what we're going to do is we're going to take a bit of a deeper dive in July's AKT report, because there are some interesting bits on there. So a bit about me. I have multiple roles, as most GPs do nowadays. I describe myself not as portfolio GP because I don't like the term, but more of a patchwork GP because everything blends into each other. I'm predominantly a GP partner, and that gets me the majority of my cash, and where I'm sort of like, I work at Eaglescliffe Medical Practice up in the northeast. I also work for Holyoke Medical School, and I'm a GP trainer and have been for the past 3 years. My first trainee from start to finish will CCT, all being well, in February of this year. Also got multiple roles within Federation, and also run a YouTube channel, Doc Support, which has a lot of the videos that you may find useful in your GP training, and I'll signpost you to a couple of them after this session as well. Also a father of 3. My wife's a local A&E consultant, which is hilarious because a lot of the GP trainees that I have will actually have been supervised by her before they get to me, which is brilliant. And by all means, I appreciate doing questions in a open forum can be rather intimidating, and you can either please feel free to chuck in questions either anonymously or drop me an email, dave@docsupport.co.uk. I'm normally fairly good at getting back to them, and then we'll take it from there. So thanks to my trainees, and it's their fault, effectively what I had 2 international medical graduates, one from Syria, one from Nigeria, who basically were really clinically were phenomenal, like hands down phenomenal, but they both really struggled with the other 20% of the AKT, i.e. the stats and the admin. From my point of view, because I'm a bit of a nerd, I absolutely sailed through this during my training, and I thought, hang on a second, let's do something about this. So you may have already seen it, that I delivered a webinar about a couple of weeks ago, just purely on stats and admin. So yeah, what we'll do is I'll signpost you to the e-learning course, give you a bit more detailed at the end of the presentation. Because of what's on the feedback report, which was rather interesting, I've actually ripped off some of the modules to put into this presentation as well. So in short, you've got plenty of time there and thereabouts. Please don't panic. What I will do is we'll highlight what was on the feedback report, and I'll give you some bits that I would think, Hank, if you're really sort of stuck and you just sort of think there's too much to revise, just that you need to focus on these 4 areas to be comfortable with, and we'll rattle through them, giving you a broad outline over this next hour in terms of where to look and what to look at from that point. So moving forward, really, you need to cover, I think, if you're doing this, in 4 areas, or 4 areas that really highlighted up. So that was prescribing in the elderly, tropical medicine, a bit about knowing about study designs, and then finally neurology. I'm going to leave neurology to last because it's very, very interesting that if out of all of these, start with neurology, and I'll tell you for why. So let's start on prescribing in elderly. So prescribing in older adults, and this was on the 12 months, basically, that they picked up that you need to be able to prescribe in older adults, interpretation of results, and drugs monitoring. Now, this is really cruel, I think, and sort of putting my trainer brain and partner brain onto it. And I think, right, I think this is what they're hinting at here is, do you know about anticholinergic burden? I wish you could say it better than I can, than I can study it. DMARDs, which is really frustrating because I don't know about you, if you're in a primary care setting, I don't touch DMARD monitoring at all. It is all done by our pharmacists and nurse practitioners, so I don't see any of this. Okay, but regardless, they're still going to sort of, and this has popped up time and time again, and I'll sort of give you my 10 penny worth of this, and also common medications and where you should drop the dose if the renal functions are reduced, because I think that's sort of where you're hinting at here. Okay, so let's briefly touch on anticholinergic burden. So I think you need to have a look at in terms of like when people are overloaded and what they could potentially be present with. Okay, so thinking about, are they drowsy? Are they restless? Have they got cognitive impairment? So thinking about your what your question may be sort of set at in terms of, you've got a patient there who's increasing confusion. Perhaps they're sort of they're trying to push you down a dementia bit, and then they give you a list of medications. We're going to touch upon those, which ones. Also thinking about salivary secretion and also retention. Really sort of classic questions from that way. Okay. So, and then think about which medications, and I've listed a whole load out here for you, okay? But think about your common ones, amitriptyline as well, okay? These aren't extensive, these medication lists. This is purely the ones that I think, hang on a second, they're the ones that are a higher anticholinergic burden, okay, that we need to have a look at. So the sort of the ones that we commonly prescribe, amitriptyline, which I always get a flashy saying like they're over 65, just be careful. And also thinking about maybe like olanzapines if they're sort of like with that way inclined. And also there was one that I was thinking about, and things like solonefacin as well, okay, and oxybutynin. If thinking that you've got all of these multiple medications that are very, very common, but in sort of what I would expect then from a question is that they would list a couple of medications, and it'll be up to you to start to highlight of going like, hang on a second, these could be anticholinergic side effects, with actually the main question being posed around that they've got a handful of these symptoms. Okay, so it's something to go away and just make sure that you're happy with and you're happy to look at. What I would look at as well, these are all the ones that are very high, but what I'd go with is actually cross correlate between, okay, out of those high ones, which ones are commonly prescribed in primary care? And that's not all of this list. There are some that are not as bad, but still have issues. Things like codeine always sort of pops up. And so you suddenly get quite easily that you could say have a elderly gentleman who's got, bladder dysfunction and chronic pain, and suddenly they're on a solonefacin, amitriptyline, and then you chuck in a bit of codeine, and then guess what? They go into urinary retention. Is it related to the prostate, or is it related to actually that he's on all these medications? So just something to go away and think about. Okay, DMARDs. I don't know how best to, apart from trying your best to be aware of certain DMARDs that we prescribe commonly in primary care, and similar with this about what bloods to take and when, and also what you're looking out for in terms of, why are you taking like the liver function test? Why are you taking a full blood count? What does agranulocytosis look like? Yes, that link that I've given you there to the NHS CKS, but I think actually realistically just focus on a handful that are commonly prescribed. I had a look down the list this morning and thought, hang on a second, out of these, the common ones that we prescribe that I sort of will sign shared care agreements on or whatnot: azathioprine, cyclosporin, hydroxychloroquine, methotrexate, tacrolimus. I think even if if you're really struggling for time, or you're really struggling to get this mentally into your brain, which I can completely understand, I would really focus on methotrexate, azathioprine as a sort of like a must, maybe sort of a bit of cyclosporin, hydroxychloroquine as well, but certainly just try and get those into your brain from that way. Okay, so thinking about renal function and common medications that you might need to sort of stop from that way, or at least alter. Okay, so metformin, common as muck in terms of medications to be prescribed, and you need to stop it if EGFR is less than 30. Great QIA to do actually if you're struggling for an audit or something to do in primary care, but certainly one that needs to be done, and it's be a very easy question to chuck into your AKT from that perspective. Okay, think about your gliflosins, so dapagliflozin, and what interestingly that BNF sort of states about two sort of stepping points from that way. So consider an additional diabetic agent when EGFR is less than 45, and what that means is that actually it's not going to be as effective because it predominantly works on the renal tubules in terms of glucose secretion. That effectively it's not going to work as well if the EGFR is, if it's not draining effectively. And what they put is some weird and wonderful. My trainee actually did a very good QIA on this, but we shouldn't be initiating it when the EGFR is less than 15. There's sort of this weird weird ground of what do you do if they're already on it, and I don't think there's any sort of set guidance, but actually it's very interesting. Then I think it would be a great question if you've got someone who's diabetic, their HbA1c is poorly controlled, and they give you a list of medications to start, but with a low EGFR, what do you start? For heaven's sake, don't start metformin, don't start gliflozin if it's less than 15, and sort of having a look through it from that way, just sort of having those sort of questions in the back of your mind. Other one, NOACs. That even though, again, if you're anything like my practice, you won't have any prescribing of NOACs. It is purely the monitoring and everything is done by the pharmacists in our practice. But unfortunately, you may still get questions on this, okay? And you're saying about if you avoid if creatinine clearance is less than 15 and that you need to half the dose if creatinine clearance is 15 to 29. You could go into that deeper because in terms of AF, it's an incredibly common condition. And so you should know this inside out, back to front. And so having a rough idea of what chance VASC is and also how to calculate a rough bleeding risk, either through has bled, is probably a common one to use. But again, thinking about sort of that two-step process of like, well, hang on a second, I've got a case and it's presenting that they are high risk of falls. What is the risk of us starting this medication versus then sort of like doing then a medication review, and it gives you clearly that their EGFR is in either that half dose regime or it's less than 15 and just say stop it from that point of view. Again, excellent QIA to do if you're looking for something. All of these would be great as just a quick audit and just what systems can you put in place for it. Cool. So that's elderly. We're going to move on from that one. So infectious diseases. So this is what was in the July AKT feedback report. So if you hear AKT 56, that's July 25, and they number all of them, okay? So the one that you're sitting is 57, believe it or not. So in AKT 56, candidates were uncertain about the appropriate tests to use in primary care for diagnosis of some important, potentially serious infectious diseases. Right, okay? Whilst many infections are diagnosed on the basis of symptoms and signs alone, absolutely. There are some conditions where diagnostic testing is indicated and candidates should be familiar and with appropriate tests. Fine, okay. So off the back of that, what we're going to do is we're going to have a look at certain conditions from that way. So I'll put the reference in the notes on the slides. From what I could find, having a quick Google search, the 5 world's deadliest diseases in 2018 in terms of number of deaths was TB, measles, malaria, influenza, and diarrheal diseases. Okay, for the sake of this, what they're looking at in terms of how I read this is, can you identify the symptoms in terms of what they presented with and then the appropriate investigation? They're not talking about treatment, they're not talking about anything else, they're talking about symptoms and appropriate investigations. Okay, so going from TB as top, thinking about sort of, are you an at-risk household or an at-risk agent? So, and sort of, are you presenting with cough lasting over 3 weeks, which is productive phlegm, and maybe even blood in that phlegm as well? Okay, have you got fever? Have you got night sweats? And is there weight loss associated with this? I think with the interesting bit in terms of where you could differentiate that, say, from a viral illness or in terms of even a pneumonia, is that I wouldn't expect a weight loss with sort of any of those common infections from that perspective. So have a look to see if they mention it as well. Also think about the locations geography wise, just sort of be aware of sort of where it's most prevalent. So if there's any mention of foreign travel, okay, or say like family relatives moving from a foreign country in, because yes, it's not particularly prevalent in the UK, but you may get certain hubs in certain groups that it is more prevalent in. So in terms of investigations, what you're looking at is sputum testing, and that you're looking for an acid-fast stain, or AFB for acid-fast bacilli or bacillus, depending on which way you go. So you're looking for AFB and you're looking for that sort of something to mention about sputum, okay? So measles presents with very vague sort of symptoms initially, very coryzal symptoms. So high temperatures, runny or blocked nose, sneezing, cough, and red, sore, watery eyes. That's your initial presentation. And then actually start to then develop after a couple of days about white spots in the mouth. These are called Koplik spots, okay? And also sort of a diffused papular rash. So just be mindful then that I would expect the most common cause for measles outbreaks is people who do not vaccinate, okay, or haven't been vaccinated with MMR, because that's the only way really they're going to get sort of the MMR bit for it. So what I would do is either look at, in the question itself, look for high risk groups and high risk patients. So it may be someone with no fixed abode. It may be someone who moves a lot. Travelers would be the obvious choice, where they haven't been able to keep up with the vaccinations and the primary care has failed from that perspective because they can't keep track of them as well. Other thoughts as well is thinking about whether actually have they come from a country where they don't have a vaccination program, or your obvious one, just to sort of like really hammer it home, is that actually they say they are vaccine refusers and they've now presented with this. Okay, so measles is incredibly serious. You would have, as soon as you get an outbreak, it hits the news quite rightly. And so just be mindful of these rough sort of symptoms. So the first initial symptoms are very vague and very sort of like coryzally in nature and could be a multitude of illnesses. And so what I think actually then really narrows it down is the red, sore, watery eyes in combination with all of these. And then actually what really hammers it home is your spots in your mouth and your rash. Okay. So testing's quite simple. Okay, it's effectively a mouth swab, and what you're looking for is a PCR testing, so polymerase chain reaction, similar as you did with COVID. So that's the sort of the real diagnostic test. As I said, we're not going to go into treatments in this sort of slide set because actually what they're asking for is investigations and what people were naff at. The last one we're going to touch on in terms of infectious diseases is to talk about malaria. Okay, so malaria typically presents with non-specific symptoms such as fever, chills, sweats, headaches, and myalgia. For those that are very, very interested and very got good eyesight, you'll notice that I'm ex-army. We took a group. My last sort of military deployment was out to Mali, so that's a high endemic area of malaria and falciparum malaria. And it was at the time where we had COVID as well, which was horrendous because we had soldiers who wouldn't take their antimalarials and actually they stopped presenting because they thought they got COVID and would be quarantined, whereas actually we had one who ended up having malaria, which was a deep, deep joys. Thankfully, he was all fine. But what you're looking at then is like, has there been a travel history? And there should be, and you need to know roughly in the world where malaria is endemic, okay? And it's still sort of endemic in these 83 countries, sort of put really in the red, that red sort of belt, okay? So sort of like mid-lower Africa, South America, and sort of the India-Pakistan area from that perspective. It can be, or it can hide itself for about 18 months or so. So don't be surprised if they sort of put anywhere like, you know, that year, 2 year sort of time frame, that it could still be that. Okay, so don't be sort of put off by that. Don't be sort of be led down by that red herring. Okay, again, the symptoms are very vague, and I'm going to sort of jump back in terms of Lee's non-specific, vague, sort of fluctuating symptoms in terms of sort of fever, chills, sweats, normally fluctuating on a 2 to 3 day cycle. Okay. Finally, testing wise for malaria is immunoassay, and what you're looking at is where effectively it's very similar to a almost like a COVID test, that you take a blood drop and then you put it onto a little card and you can drop it in and it will sort of get you there very quickly. That is the Acute is one example of it. Okay, and that's a rapid point of care malarial testing kit. So when I was in my military med center as a GP, we used to have a handful of these because obviously we get soldiers coming in and out of malarial zones. Okay, and basically would be like, right, come on, you could be potentially at risk. We need to rule this out. When you go into the big shiny building, it will be a blood thick and thin film. But just be careful that you might have those two sort of different areas in terms of immunoassay as your first point of contact testing, and then sort of a blood thick and thin film as your second line from that way. Okay. Now, I got overexcited with this one. Okay, so this is taken from, again, the AKT feedback report. So candidates appear to lack familiarity with terminology used to describe study designs commonly used in general practice, for example, when reviewing clinical outcomes. There was also lack of familiarity with terms used to describe common issues with data collection and interpretation. We do not expect detailed knowledge in these areas, but candidates should aim for a practical understanding of commonly used research and statistical terminology. Now, this sort of goes back to the other 20% and why I sort of hammered it home, and we'll touch upon this. But what I've done is I've ripped out one of the modules that we did in terms of basically giving an overview of evidence-based medicine, and we're going to spend the next sort of 10-15 minutes just sort of going through it to make sure that everyone's happy with it. So we can talk about which study is best, but actually there are good and bad points for all these studies, okay? Generally, top of the door, systematic reviews and meta-analysis, and then you drop down further to randomized control trials, cohort studies, case control studies, and that sort of case series and case studies, and then finally expert opinions and editorial. Now, because we're in a primary care setting, just be mindful that actually, there are a wide range of different reasons and things move quickly. Okay, so an expert opinion, just because it's someone's opinion doesn't mean it's wrong. Okay, normally based on experience and they thought and looked into it, don't write it off. They might be right. They've maybe not had time to look into it or to study it. They've not had the money to look into it, and is studying supportive in that environment. Okay, and just think to yourselves, if you've done, say, like an orthopedic rotation, classic one, or any form of surgical rotation, how many orthopedic surgeons throughout their training have got a publication? Okay, probably I would estimate sort of like at least 60% plus. Okay, they need to have that amount of publication because it's so competitive in terms of their job role that they push forward. Now, reflect that against how many GPs have got a publication. Okay, I would hazard a guess it's probably less than 5%. I don't know that for certain, but that's sort of like, just go around your practice if you're there and ask, okay, how many of you got publications? So I'm a failed orthopedic surgeon, or a reformed orthopedic surgeon, depending on which way you want to do it. So during my foundation years, I was getting publication. I then presented that at when I went for my GPs, and they're like, yeah, hardly anyone has any publications. Okay. Thinking about, though, if you're pushing things forward into certain areas that actually all you've got is expert opinion. So I'm a big sort of fan of trying to use YouTube, social media in terms of trying to promote patients' health. And so actually, when I look around in terms of the evidence, there isn't any meta-analysis, etc., etc. So when I'm trying to publish things and push things forward, I can't reference anything else. Okay, so it's one of those of like, even though it's there, it doesn't mean I'm wrong, potentially, just means that there isn't the evidence base there for it. So think about case series, okay? Again, sort of moving things on. This is sort of a group of people with a condition that you've written up, okay? So it can be relatively quick and simple, and it's really, really useful for studying rare events. You don't need control groups because you're just doing a handful of patients. The problem is, though, it's quite limited in terms of what it can do, and there's inherited bias in terms of the selection, and actually it's sort of limited in terms of the conclusions that can be drawn. Now, interestingly, so I've got a case series which just reflects at how easy it is to actually get one written up and sort of published from that way, potentially. So this was an incredibly rare condition, exercise-induced anaphylaxis, which, to be honest, until I saw this patient, I was not aware of this whatsoever. What's even more sort of rare and niche about this is that not only is it rare in terms of the condition, but this was a patient who was pregnant, and so how do you manage labour? So you've got this then very rare condition, an even rarer sort of circumstance, hence why having a case series is quite useful. You sort of have a look through the literature and there was hardly anything on it at all, and so that's why we need to sort of be mindful of where these case series and case presentations are actually really useful and really great to have it from that way. Okay. So you've got case control studies. You compare people with the condition versus those that don't have it. And what you're looking at with the case control is that it will be a single interview with a researcher, and they're asking them basically their life story. They're sort of going back in time to sort of go like, right, what happened when, when you were 10, talk me through this. And basically you will have a group who have got the condition, okay, and you've got a group who don't have the condition, then you're going to compare the two, okay? Because it's retrospective, it's going to be difficult and it's going to be highly prone to recall of the events. Just think to yourself, what did you have for lunch last Monday? Okay, you probably don't remember. I certainly don't. And so it's that, even just that memory, and when you're asking things potentially from months, years ago, that you need to be aware of it. Off the back of this, you can pull out an odds ratio as well, but again, that's limited in terms of what you can do. The benefit, though, is that they're very cheap and they're very quick to do, because all you're doing is you're just interviewing people and then that's done. So actually, once you've got the interview sorted, in terms of that information it's probably only going to be a couple of months, which in terms of research time is nothing. The issue, though, is sort of confounding risk. So, for example, how do you pull out your control groups versus your actual, people with the condition? Okay, so that is incredibly, incredibly difficult to do. And again, we've already talked about the risk of recall bias. Causation as well is unlikely to be proven in these cases, because of, there's so many variables that you just can't sort of pull apart and sort of be able to get hold of. And also, control groups are really difficult to sort of get hold of, because are they truly a control group? Because there will be some overlap, especially if you're in the local same geographical area, etc., etc., etc. It's full of pitfalls. Where it is, though, good is starting to build your preliminary studies, okay, and start to build that research base and start to build the evidence in that area. The idea then is that you can have that, and one of your conclusions will be more studies are needed, but actually you to push things forward. Okay, so the main bit when you've gotten these questions is that you're looking at two groups or potentially more, and you've got potential people with the condition and without it, and it'll be retrospective. Okay, so they've asked people what happened in the past. Okay, so cohort studies, slightly different from that way, because we're moving sort of moving a bit different way, and we're taking a series of people who've been exposed and watches them over time, and you're looking at a longitudinal study. Okay, so effectively with that one, what you're doing is that you've got, like, right, I'm getting a snapshot of people, and we're going to follow them for perhaps 5, 10, 15 years and see what happens to them. Okay, now, we've got one that's just happening locally in terms of a dementia study. And what they're doing is they're trying to sort of like get a large group of people and basically say, like, right, come on, let's follow you and see what happens from that perspective. And what you're looking at potentially as well is, you could say, get a group of people who've been exposed to a large amount of radiation or some event that may have happened, and then follow them up over a long period of time and just sort of like just see what happens. Problem is, though, there's high risk of confounding, because you can't really predict the future. You don't know what's going to happen moving forward. And so effectively, you're like, right, come on, let's just follow you and see what happens. Okay. One key example is the Framlingham Heart Study. That's a famous experiment where people were followed in terms of trying to identify their cardiovascular risk. Okay, so again, with this, it's cheaper than randomized control trials, and you're looking at sort of causal relationship. Because you're looking at a large group of people over a long period of time, you may be able to identify these very rare risk factors that sort of pop up that you're just unaware of. And actually, you can start to measure incidence, because you've got a group of people coming out over time. And because you're not being that sort of like narrow in terms of what you're doing, you may actually find that you initially went into it thinking, like, right, well, smoking's bad for dementia. But then, as it turns out, you do this study into dementia, and it turns out that people who exercise more have a significant impact versus smoking. Okay. But you didn't go into that initially just to think about it from a study point of view. Okay. And it reduces suspicion bias, because you're not selecting people of like, oh, I like you, I don't like you, etc., etc. You're just taking a broad snapshot of people from that way. Disadvantage: you can't randomize it, you can't blind it, and you need a huge amount of numbers to make this sort of worthwhile. And again, because it's huge numbers, it's going to cost you. Okay, the cost as well is going to be a couple of bits and pieces in terms of the people actually to identify, and also people are going to drop out from that point of view as well. Okay, and you're going to get sort of a confounding factors. Sorry, I saw a hand raised. Or do you want to type it into the Q&A what your question was, and I'll sort of answer it as we go. So from that way, and it's not very useful for for it. Moving on to randomized control trials. Okay. What we're going to do from that way is this is sort of like you're hitting the gold standard of research. You're looking at two groups who've been randomized into two groups, both the treatment and control, and you can get a crossover, i.e., that they're treated and then they have a washout period and you basically swap the groups as well. The advantages for this in terms of it's unbiased, okay, and you can blind people. That what I mean is that the participant doesn't know what they're getting, okay, in terms of the medication or treatment, etc. And that's a single blinding. You can double blind it if the researchers don't know as well, okay, and you can get some more powerful statistical analysis from that way. Big problem is that it's expensive, it's hugely time consuming, and also there are ethical issues and concerns from that perspective. Panoramic study was done with regards to COVID, looking at whether cyclovir can be used, and from that perspective, I still haven't seen the results from that, and that's been going for years. And then you're in this horrible position now, whereas actually for COVID, we just almost let the people live with it, apart from those who are really, really ill. So actually, from a primary care point of view, it's not much use. But anyway. Finally, meta-analysis, we'll sort of touch upon that. What we're doing is we're getting multiple randomized control trials and we're comparing them across the board, okay? The advantages for this is that it's huge in terms of the highest level of evidence, and you can draw some large-scale conclusions, and multiple studies across different areas can be sort of compared and contrasted. There's a high cost, though, in terms of time, because if you think you've got to have all these randomized control trials sort of like lined up, and then you've basically got to be able to compare them, and there's a risk that studies don't match in terms of their study outcome. There's also publication bias, which means that certain publications, certain results will not be published, okay, and that will mean that whatever evidence you've got is poor and basically doesn't sort of give you a sort of a handle for it or an outcome. Okay, so that is, just a very, very brief overview of study designs. Okay, for each of those, certainly for meta-analysis, I would strongly implore you that you need to be able to at least have a look at forest plot and be happy with how to do it. With regards to randomized control trials, or numbers needed to treat, etc. You need to be happy with how to calculate those with your odds, with your cohort and your case control studies, calculating risk ratios and odds ratios as well from that way. As I said, that is effectively why I did the course, because it nails down all of this area, okay, for it. So final stretch, I'm conscious that people need to grab their lunch and pretend, and like myself, start off with clinic. Thankfully, don't kick off till 1:30. Now, this is interesting. So again, I've copy and pasted this from the AKT feedback report. So this needs to be, if you're going to do one thing off the back of today, please go and revise some neurology. I know it's dull. I really struggle with neurology, but you need to read about it. So we repeat the feedback that we provided after 3 of the 4 sittings of the AKT exam. So RCGP, I think, have left a bit of a clanger in here, because what they've said is that out of the last 3 AKTs in the year, so for a year, they've had a neurology question. Okay. And it's like, this to me is like, whoa, you've just given this all away basically from what is going on and sort of like what's happening from that way. Okay, namely that while it is often difficult to make definitive clinical diagnosis from possible neurological signs, we encourage candidates to be aware of combination of symptoms and all signs which are typical for particular conditions. Blah. And you're like, thanks for that. That really doesn't help me whatsoever. So I've put my sort of trainer brain on and gone like, right, what do I think? I actually ran this past my wife as well with her A&E hat on and saying like, so what you definitely need to know and be confident with, which I think everyone should be at this stage of the game, is stroke TIAs and your weird and wonderful headaches, okay? And when I say headaches, I mean also your red flag headaches as well, thinking about if you've got space occupying lesion or something there as well, okay? Cauda equina syndrome, because we're talking about neurology just as an emergency, needs to be aware of and needs to be mindful of this as well. What I think, though, they're hinting at is your weird and wonderful dizziness. Okay, so can you diagnose a cerebellar stroke off the back of this? And sort of like think about like your Meniere's disease, these sort of like really weird and wonderful ones. What I'm going to spend the last bit of, because I think actually what they are talking about, what I really think they're hinting out, is the progressive neurological conditions, which basically are the ones that everyone hides away because they're really horrible and they're really poorly diagnosed in primary care because they come with such vague symptoms that they're picked up either late or with a long protraction from initial presentation to final diagnosis. Okay, so multiple sclerosis, motor neuron disease, and progressive supranuclear palsy. Okay, so we're going to touch upon these briefly. So thinking about MS, so MS is your sort of your first one, and what I'd have a look at is basically oh, sorry, I'm just going to answer Adrian's question. So when you're saying neurology questions were in the exam, isn't it meant to be question, or does a proportion of different topics was skewed and they used more neurological questions compared with other topics? Oh, good question, Adrian. So what I'm saying is, for a start, I can't guarantee a thing. Okay, and I apologize in advance. I'm not saying have no impact or no sort of no sort of say so with the RCGP. What I am sort of hinting at is that if the looking at this and looking at the feedback report, it's saying that basically out of the last 3 of the 4 exams, they've had neurology questions in, okay, that basically people got them wrong because otherwise it wouldn't be on the feedback report. And effectively, there is an unwritten rule that if people keep getting it wrong, they're going to ask it again. So guess what? You've got 3 weeks to go. Make sure that you sort of at least swept up in terms, or sort of like are happy with your neurology, and being mindful of that. Again, not a guarantee, but on the flip side, if you do get it, you can send me a Mars bar equals Live Medical Practice. But anyway, it's by the by. Hope that answers your question, Adrian. So, um, from that way. So main symptoms of multiple sclerosis have just got sort of this sort of the ones that I would pick out in terms of what would make a great question is optic neuritis. Okay, and that's often where the red colorings will go to grey, so they can't see things as clearly from a red point of view and sort of going to grey, and that is often one of the first first sort of symptoms that can be picked up, maybe tied in with sort of also looking at pale optic discs as well. So you may get it where the actual, if you can imagine a question in your head where they're saying like, they've just come from the opticians and they've commented about, their discs look a bit pale, etc., etc. MS as well is sort of like these very, very vague symptoms in terms of like muscular weakness, cramp, spasms, okay, increasing sensitivity to sort of like burning, tingling, etc. And also these vague sort of like fatigues, depressions, and cognitive impairment, okay, from that way. So again, that's where I would sort of have a look at in terms of, if they've got visual changes, which is often one of the first symptoms, okay, sort of like slurring, incontinence, and it starts to build up this picture in terms of it thinking like, could this be multiple sclerosis? Okay, because from looking at that question, what they're looking at is in terms of diagnosis. They're not actually talking about investigation, because realistically, your investigation for all of these is going to be pretty much the same, either an urgent referral to neurology and some form of imaging. And it very much depends where you're at in the country, whether they expect you to do it or not. Okay, so we're going to touch upon about MND. Okay, this is from a really good Pulse article talking about zebras, and they're looking at different sort of features in terms of like, right, have they got slurred speech or quiet speech when tired, dysphagia to either liquids or solids, excessive saliva, or they sort of like choking sensations, and they have got tongue fasciculations. I think that tongue fasciculations would be a real like boom. They expect you to know it from that way. Because again, looking at the limb features, these are so vague, okay, in terms of focal weakness, falls and trips, and loss of dexterity that you just sort of don't know about it from that way. Moving on to then respiratory symptoms, sort of odd respiratory symptoms in terms of like shortness of breath, excessive sleepiness, fatigue, and then thinking about, could they have an early morning headache because they're slightly hypoxic or orthopnic as well. And then thinking about these very sort of vague behavioral changes in terms of emotional lability, and frontotemporal dementia. Okay. Is there progression? So supporting factors, age, so it can present at any age. So think about, okay, if you're looking at these conditions, certainly with like your focal symptoms, as it can present at any age, if you're suddenly getting like a 40 or a 50-year-old who's actually physically fit and well, and you're thinking like, oh, they're painting a classic stroke picture, well, actually, could this be MND? Okay, just thinking about that. Whereas actually, if they're older, maybe they've got high cardiovascular risk factors, then actually could this be that? Okay, positive family history of MND or other neurodegenerative diseases. Okay, and thinking about here, factors not supportive of MND, bladder bowel involvement, interestingly. So actually, if you've got in there, if you've got that in the little question bit, then actually that's not suggestive of it. Predominant sensory symptoms. Okay, again, another tick. Double vision, orthosis, and improving symptoms. Okay, so thinking like, could this be towards more the MS? Sorry. If yes to one and two, and query query MND and refer to neurology. Okay, so again, I've got a link to this. I'll sort of will make sure that we get it to you afterwards. Okay. So lastly, you've got your PSP, your progressive supranuclear palsy. Okay, this is sort of a Parkinsonian type symptoms. Okay, but thinking about your main sort of symptoms in terms of difficulty in controlling eye movement in the upwards and downwards direction. Okay, loss of balance, and certainly falling backwards. I think that would be quite an interesting question if you sort of like, how are they falling? You know, are they going forward, backwards, etc., etc. And also speech and swallowing, sort of like progressive PSP involves the muscles for speech and swallowing. And so actually thinking about that as well. Okay, phew. So it's 1:45. Just to say that, okay, so off the back of the July AKT feedback report, these are 4 areas that if you're sitting your AKT in October time, make sure that you give yourself time to sort of factor them in. Start off with neurology and work on the others. Okay. I just want to highlight as well, sort of like I do bang on about this a lot. Thanks to my trainees, I created an online e-learning course which is called The Other 20%. Okay, it contains 16 modules which basically cover, guess what, the 20% of the exam. Okay, you can see all of the stats modules there, 1 to 10. Interestingly, to get what I gave you was module 6, the outline of evidence-based medicine, but actually to get a real deep dive on it, 7, 8, 9, take a deeper dive in terms of these individual studies and what you can nail out of them. Okay, so effectively for that potential questions, you've got 4 modules there. The admin side is 1 to 6 in terms of like all the sick notes, DVLA rules, aviation rules. The patient practice interaction is more about registration, what to do after they die. GP contracts as well is really useful to know just in terms of sort of moving things forward. Duties of a doctor is a very, very good question to ask. And also I touch upon social media, which is always a good one to ask as well. I do offer variations. You know, if you do get access to the course, you get everything basically. But what we do is we time dependent on it. So if considering you got 3 weeks away, the 1 month full access, you get 15% off because you've given up your time this lunchtime for it. So it works out at just under £42 for the sort of the month. Okay. I'm hoping whether anyone in the chat has actually tried it and could either say how they're finding it from that point of view. I'm going to shut up now. If you've got any questions, please feel free to put them in the Q&A. And then we'll take it from there. I will be here for the next sort of 10-15 minutes. So by all means, chat in your questions, or if you've got anything else or anywhere else to be, by all means, please do that. So I'll hand over to you and hope you found that useful.